Welcome to the deep dive. Today we're jumping into a really foundational section of Lewis's Medical Surgical Nursing, the 12th edition, our mission, to really explore homeostasis and protection. It's all about how the body keeps its balance, defends itself, and, well, what happens when things go wrong. Think of this as your shortcut to grasping these core ideas.
Absolutely. And what's so interesting here is how these topics, inflammation, immunity, genetics, infection, cancer, fluid balance, they might seem separate, but in reality, they're constantly interacting within the patient. Understanding those connections, that's key for good care, for critical thinking.
Okay, let's break down that first big one. The inflammatory response. We hear inflammation all the time, sometimes mixed up with infection. So what is it really? How's it different? Well, at its heart, inflammation is the body's organized reaction to any cell injury. Its job is to neutralize the bad stuff, clear out damaged tissue, and get ready for healing. And here's the crucial difference. You always have inflammation if there's an infection. Always. But you don't always have an infection just because there's inflammation. Think of sprained ankle, right?
Yeah.
Or burn. That's inflammation without infection.
Exactly. So when that injury hits, the body kicks off this two-part response. First, the vascular response. What happens is blood vessels near the injury constrict for a sec, then they dilate, and they become more permeable. That lets fluid and proteins flood the area. That's why you get the redness, the heat from more blood flow, and the swelling from that fluid leak. Makes sense.
Okay, so that's the vascular part. What's the other prong?
That's the cellular response. This is where the white blood cells come in, your defense team. Neutrophils, they're the first responders, usually within hours. Think of them like a little Pac-Man gobbling up bacteria and debris. Then come the monocytes. They arrive a bit later and turn into macrophages, the big eaters. They handle the larger cleanup and really orchestrate the repair process.
So inflammation is protective, but when does it become a problem? Like take fever. It helps fight infection, usually. But when do we, as nurses, step in?
Right. A moderate fever, say up to 102 Fahrenheit, is generally okay, even beneficial, but we start thinking about antipyretics fever reducers for the very young, the very old, or patients who are really uncomfortable, maybe have serious heart or lung issues, or are immunosuppressed. Why? Because really high fevers, like over 105.8 Fahrenheit, can actually damage cells, particularly brain cells. And here's a key thing to watch for.
Okay.
Older adults, they often have a blunted fever response. Their temperature might not go up much, even with a serious infection, so you need to be extra vigilant with them. Beyond fever, for local inflammation, you know the acronym IC.
Oh, yeah. RACE. Rest. Ice.
Right. Compression and elevation. Ice is usually best right after the injury to constrict vessels. Later on, sheet can actually help by boosting circulation to clear debris.
Okay, so the inflammation happens. The body fights back. What about healing? How does the body actually repair the damage?
Good question. Healing happens in basically two ways. Regeneration is when the lost cells get replaced by the exact same type of cell. Think of a minor paper cut. It heals without a trace. But more often, especially with bigger injuries, we see repair. This is where connective tissue, basically scar tissue, fills in the gap. And understanding how wounds close is crucial for us. Primary intention, that's your clean surgical cut. The edges are brought together neatly, minimal scarring, heals fast.
Like stitches.
Exactly. Then there's secondary intention. Think of a big pressure injury or a large irregular wound. The edges are far apart. It has to heal from the bottom up and the sides inward. Takes longer, usually leaves a bigger scar. And there's also tertiary intention or delayed primary closure. That's when a wound is dirty, so we leave it open on purpose to let it drain, clean it out, and then suture it closed later.
This is where it gets really practical for nursing, right? When healing doesn't go as planned, what kind of complications should we be watching for?
Oh, definitely. You can get things like adhesions, which are like internal scar bands sticking organs together where they shouldn't, or contractions, where the scar tissue tightens up so much it limits movement, especially over joints. So our job starts with really good wound assessment. Location, size, depth, what the wound bed looks like, the color. Is there drainage? How much? What color? Any odor. How's the skin around the wound? Signs of infection, pain.
Got it. That assessment drives everything.
It really does. And our care often focuses on creating the best environment for healing. Usually that means keeping it moist and clean. We typically use non-cytotoxic cleaners like normal saline. Dressings are huge. Hydrocolloids, for instance, they're good for wounds with light to moderate drainage. They form a gel, absorb fluid, and help the wound clean itself, essentially. And we have advanced stuff, too, like negative pressure wound therapy or NPWT.
Ah, the wound vac.
That's the one. A vacuum pump creates negative pressure over the wound bed. It pulls out excess fluid, reduces swelling, and actually stimulates new tissue growth. We use it a lot for things like diabetic foot ulcers, complex surgical wounds. It can make a huge difference.
Okay, quick scenario then.
Yeah.
You're assessing that diabetic foot ulcer. What are you looking for, and how would NPWT fit in? You'd be checking, the size, depth, drainage, any signs of infection like redness, warmth, odor. Is the surrounding tissue healthy? For NPWT, you'd make sure the wound's clean, cut the special foam dressing to fit right in the wound, cover it with an occlusive film, hook it up to the pump, and set the negative pressure. Precise assessment leading to a specific intervention.
Exactly. Now let's talk about another huge issue, pressure injuries. These are such a major concern. Who's most at risk?
Well, definitely older adults, people who can't move much, anyone incontinent, patients confined to bed or a wheelchair, basically anyone with prolonged pressure on their skin.
Right. And knowing the stages is fundamental. Stage 1 is that persistent red area on intact skin that doesn't blanch, doesn't turn white when you press it. It goes all the way to stage 4, which is full thickness, tissue loss. You might even see muscle or bone. Then you have unstageable, where you can't see the bottom because of SLA or Escher, and deep tissue pressure injury, DTPI, which looks like a deep bruise, purple or maroon, but the skin's intact. So the big question, how do we prevent these and manage them when they happen?
Prevention is key. Repositioning specialized mattresses.
Absolutely. Offloading pressure is number 1. Frequent repositioning schedules, pressure-reducing surfaces like special mattresses or cushions, meticulous skin care, managing moisture. For treatment, it's about cleaning the wound gently, maybe debridement if needed, appropriate dressings for a moist environment. And one really important warning, never massage those red, non-blanching areas. It can actually make the damage worse. Plus, patient teaching about nutrition, staying hydrated, moving as much as possible, it all plays a role.
Okay, let's shift gears. From skin integrity, let's zoom right down to the cellular level, to our genes. How does our genetic blueprint affect health and defense?
It's fundamental. Our genes, those segments of DNA, hold the instructions for everything our cells do. The Human Genome Project, finished back in '03, was a massive leap. It really opened the door to understanding disease risk, diagnosis, and maybe most importantly for us now, personalized medicine.
Personalized medicine. That brings us to pharmacogenomics, right? Tailoring drugs based on genes. How does that work in practice?
It's fascinating. Instead of giving everyone the same dose, pharmacogenomics looks at how your specific genetic makeup affects how you metabolize and respond to drugs. We can predict sometimes who will benefit most, who might need a different dose, or who's at high risk for side effects. Take warfarin, the blood thinner. Variations in 2 genes, CYP2C9 and VKRC1, really impact sensitivity. Knowing a patient's variation helps us pick a safer starting dose.
So less risk of bleeding or clotting?
Precisely. Or another example, clopidogrel, Plavix. It's an antiplatelet drug. Some people have a variation in the CYP2C19 enzyme that makes it less effective for them. So maybe they need a different drug. It's about getting the right drug, right dose, right person. But it also raises ethical questions, privacy of genetic info. That's why we have laws like GINA, the Genetic Information Non-Discrimination Act, to prevent misuse.
Makes sense. Okay, so from genes, let's move to the immune system itself, the body's defense force. How does it recognize invaders and fight them off?
It's incredibly complex. You have organs like bone marrow, the thymus, and key cells. B lymphocytes, they make antibodies to fight stuff floating around outside cells. That's humoral immunity. Then you have T lymphocytes. They mature in the thymus and are the fighters involved in cell-mediated immunity. They directly attack infected cells, tumor cells, fungi, like the ground troops. And it's important to remember, as we age, the immune system tends to slow down a bit. It's called immunosenescence. That's partly why older adults are more prone to infections, cancer, and might not respond as strongly to vaccines.
But sometimes the immune system goes haywire, doesn't it? Either overreacting or attacking the body itself.
Exactly. Overreactions are hypersensitivity reactions. And when the body attacks itself, that's autoimmune disease. Let's focus on type hypersensitivity, especially anaphylaxis. That's the really severe, life-threatening one.
Right, the classic allergic reaction gone systemic.
Pretty much. In someone who's highly sensitized, when they encounter that allergen again, IgE antibodies on their mast cells and basophils trigger this massive release of chemicals like histamine. It can cause local reactions like hives, or it can rapidly become systemic, affecting breathing, blood pressure. It's an emergency.
Okay, let's do another scenario. You're giving IV antibiotics. Suddenly your patient gets chest tightness, starts coughing, their BP drops. What do? First priority, drug of choice.
Okay, first priority is recognize anaphylaxis. Then maintain that airway, ABCs, right? Airway, breathing, circulation. The drug of choice is epinephrine, given intramuscularly or IV. Epi works fast to counteract the effects of histamine, opens airways, raises blood pressure. Then you treat for shock, give fluids, monitor closely. Speed is everything.
Absolute critical. And the flip side, autoimmune diseases, where the body attacks its own tissues, often a genetic link, maybe triggered by something like a virus.
Mm-hmm.
This whole idea of the immune system recognizing self versus non-self is also why HLA typing, human leukocyte antigen matching, is so vital for transplants, isn't it, to prevent rejection?
Exactly. You want the donor organ to be as close a match as possible to the recipient's HLA type so the recipient's immune system doesn't see it as foreign and attack it.
Okay, let's pivot to another major threat,
Yeah.
infection, and especially those tricky ones we encounter in healthcare.
Right. We deal with emerging infections like COVID-19 was initially. New diseases or known ones spreading differently, maybe due to animal contact or drug resistance. And then there are healthcare-associated infections, HAIs. These are infections patients get while receiving care. It's a huge issue. About 1 in 25 hospitalized patients gets one. And the sobering part, many are preventable, often spread by us, healthcare workers, if we're not careful with things like hand hygiene.
Which brings us straight to nursing management. What are our biggest weapons against infection spread?
It starts with risk assessment and creating a safe environment, but honestly, the most powerful tools are simple. Meticulous hand washing or using alcohol-based hand rub, and using personal protective equipment, PPE, correctly, gloves, gowns, masks, eye protection when needed. These basic things interrupt the chain of infection. Plus, educating patients about finishing their antibiotics is crucial to fight antimicrobial resistance.
Let's talk about HIV. How does it work? And what's key for us to understand now?
HIV is a retrovirus transmitted through specific body fluids. It targets and destroys CD4 plus T cells, which are vital immune cells. As the CD4 count drops, the immune system weakens. This leaves the person vulnerable to opportunistic diseases, infections, and cancers that wouldn't normally cause problems in someone with a healthy immune system. These are often what lead to serious illness or death in advanced HIV, or AIDS. A really important concept now is antiretroviral therapy, ART. The goal of ART is to suppress the virus so much that it becomes undetectable in the blood.
And undetectable means?
It means the viral load is so low, standard tests can't find it. And crucially, someone with an undetectable viral load cannot transmit HIV sexually to a partner. UU. Undetectable equals untransmittable. It's a huge message for reducing stigma and promoting health. Doesn't mean cured, the virus is still there, but transmission risk is eliminated.
That's incredibly important. Okay, shifting from infections to another major challenge to homeostasis.
Yeah.
Cancer, uncontrolled cell growth.
Right. Cancer happens when the normal checks and balances on cell growth and differentiation go wrong. You have proto-oncogenes, which normally regulate growth. They can mutate into oncogenes, which promote uncontrolled growth, or tumor suppressor genes, which normally stop abnormal growth, can become inactivated. There's often a long latent period between the first genetic changes and the actual appearance of cancer. Then the cancer cells can grow, invade nearby tissues, and potentially metastasize, spread to distant parts of the body. That ability to invade and metastasize is the hallmark of a malignant tumor versus a benign one which doesn't spread.
So how do we approach treatment? What are the goals?
Goals can be cure, control, like managing a chronic disease, or palliation, focusing on symptom relief and quality of life. Treatments vary widely. You have surgery, chemotherapy. Chemo is systemic, travels throughout the body. It targets rapidly dividing cells, which includes cancer cells, but also healthy cells like those in bone marrow, the GI tract lining, hair follicles.
Leading to those common side effects: fatigue, nausea, hair loss, low blood counts, mucositis.
Exactly. Then there's radiation therapy, which uses high-energy rays to damage cancer cells locally. It also causes fatigue and skin reactions in the treatment area. And we have newer approaches: immunotherapy, which boosts the patient's own immune system to fight the cancer, and targeted therapies, drugs designed to block specific pathways that cancer cells rely on. Our nursing role is huge here, managing all those side effects, watching for emergencies like tumor lysis syndrome or spinal cord compression, managing pain effectively, and providing that vital emotional support.
Absolutely. Okay, final major area. Bring it all back to the moment-to-moment balance, fluids, electrolytes, and acid base. The body's internal equilibrium.
The foundation. Our bodies are mostly water, split between intracellular fluid, ICF, inside cells, and extracellular fluid, ECF, outside cells. Dissolved in this water are electrolytes, charged particles like sodium, potassium, calcium. How water and solutes move is key. Diffusion is movement from high concentration to low. Osmosis is water moving across a membrane towards the area with more solutes, trying to equalize concentration. This relates to tonicity of IV fluids. Isotonic fluids have similar concentration to blood. Hypotonic fluids are less concentrated, making water move into cells. Hypertonic fluids are more concentrated, pulling water out of cells.
And imbalances can cause big problems. Too little fluid volume deficit or hypovolemia gives you dry membranes, maybe low BP, poor skin turgor. Too much fluid volume excess or hypervolemia leads to edema, swelling, maybe shortness of breath if it backs up into the lungs. Nursing management. Strict I&O. Daily weights are crucial. Skincare safety precautions.
Definitely. Now let's hit two critical electrolytes, sodium and potassium. Sodium is the main ECF ion. Hypernatremia, high sodium, often means dehydration. It shrinks brain cells, causing confusion, restlessness. Hyponatremia, low sodium, usually means too much water. It swells brain cells, also causing confusion, seizures. You have to correct these imbalances slowly.
Right. Slow correction is key. And potassium.
Potassium is the main ICF ion, vital for heart function. Hyperkalemia, high potassium, is dangerous. It makes the heart muscle too excitable. You see those classic peaked T waves on the ECG. It can cause lethal dysrhythmias, muscle weakness. Hypokalemia, low potassium, makes the heart unstable too, can cause weakness, maybe U waves on ECG. And the absolute safety rule, never give IV potassium push. Always diluted. Infuse it slowly.
Okay, quick check again. Patient has muscle weakness. ECG shows peak T waves. What electrolyte? Priority action.
That screams hyperkalemia. Priority is cardiac monitoring. Stop any potassium sources, maybe give calcium gluconate IV to protect the heart, then work on lowering the potassium level with things like insulin glucose, kayexalate, or dialysis if severe.
Perfect. And finally, acid-base balance, keeping that blood pH in the tight range of 7.35 to 7.45.
Yeah, tiny changes here have big effects. Your body uses buffers, and your lungs, controlling CO2 and kidneys, controlling bicarbonate and acids, work constantly to maintain this balance. Imbalances can be respiratory acidosis, retaining CO2 like in COPD, respiratory alkalosis, blowing off too much CO2 like hyperventilating, metabolic acidosis, too much acid or loss of bicarb like in kidney failure or DKA, or metabolic alkalosis, loss of acid or too much bicarb, maybe from vomiting. Understanding the causes and compensations is key.
And we manage a lot of these fluid and electrolyte issues with IV fluids, using isotonic, hypertonic, or hypertonic based on the problem. For longer-term access, we often use central venous access devices, CVDs, PICC lines, ports.
Right. CV aids are great for reliable access, giving meds that are tough on peripheral veins or for long therapies. But they come with risks, mainly infection. So, meticulous care is non-negotiable. Strict sterile technique for dressing changes, assessing the site constantly, flushing properly to maintain patency, and watching for complications like dislodgement or thrombosis.
So wrapping this all up, what's the big picture for a nursing student from this whole section on homeostasis and protection?
I think the biggest takeaway is realizing just how interconnected everything is. Inflammation impacts fluid balance, genetics influences drug response, which affects infection treatment, cancer therapies disrupt immunity and fluid balance. It's all linked. It's not just memorizing facts about each system in isolation. It's about seeing the patterns, understanding how a problem in one area creates ripples elsewhere. That's holistic care. That's critical thinking in nursing.
Exactly. It's about applying the nursing process assessment, diagnosis, planning, intervention, evaluation across all these complex situations. We hope this deep dive gave you that shortcut, connected some dots, and built a stronger foundation for you. There's always more to learn, right? So keep asking questions, keep exploring these vital concepts as you encounter them in your studies and practice. From everyone here at the Last Minute Lecture team, thanks for joining us. Keep learning, keep growing, and go make a difference.